there will be decreased hormones, so there will be decreased fertility as well as decreased bone density due to lack of estrogen.
All right. Okay. All right. Um, Actually, I'm looking for keywords. Yeah. For example, is primary ovarian insufficiency. Yeah. Is characterized by what? What are the criteria that actually say that this patient is primary ovarian insufficiency? So it must have some data to support this what you call it, the diagnosis. And you say about hormone. You would not, when you define primary ovarian insufficiency, you need to be specific of what hormone that you are actually referring to. This patient under osteoporosis ka?
Not yet.
Not yet. That means that you cannot say this patient is POI. If you give me that definition that the patient must have osteoporosis, then it's POI, then this definition is not very true, isn't it? What is the okay, I need to check your learning issue on your definition of POI. Hold on, yeah, and I have to check back your POI learning issue. Okay, I find it. Explain the term primary ovarian insufficiency. All right, primary ovarian insufficiency, also known as pre-major ovarian failure, happens when a woman ovary stop working normally before she is 40. I'm reading from your text. Yeah? Reduced fertility, getting irregular menstrual periods as they transition to menopause, cannot get pregnant. Right. Okay. I want to rectify on this definition. Yeah. Okay. Primary ovarian insufficiency. Yeah, is characterized by what the characteristic that in POI.
Is it the low FSH?
Yeah, low estradiol.
Okay. Yes, hypoestrogenism or low estrogen level, and or also you also I think there's a low FSH as well, but elevated gonadotropic hormones, isn't it?
Let
Yes,
me
doctor.
check, doctor. Yeah, is it?
Okay, back to is that you're saying that this patient diagnosed with POI, it must have a lab investigation to support it. So the characteristic is what?
Doctor, do you want me to open the lab?
Because I'm also addressing the learning issue, that's why I'm saying is that
the FSH is 45, so it's pretty high, I think. Is it?
okay, what in your opinion that this patient have POI? By what it needs some evidence. Yeah, remember your method is evidence based. So what is the what do you think what that pointed to this patient having POI?
I think from the lab, when we see the FSH and LH high, but the estrogen and progesterone low.
Right. So that means that when you say that this patient is diagnosed with POI, and the evidence is that the patient must be amenorrhea, hypoestrogenism, that means low estrogen. Most important is low estrogen, and also over here is low estrogen and low progesterone. The reason is because that what you call it, high serum gonadotropic hormones like folic FSH and LH, isn't it? So the age is that this patient is actually less than 40. So that is the characteristics of POI. Understand?
Understand means.
Right, so your learning issue number 12, explain the term primary ovarian insufficiency. Information before the age of 40 is important, but you did not include is that what is the, what you call it, the for example, is that like PCOS, one of the definition of PCOS is that the androgen must be very high, yeah, or testosterone is must be very high. But for this POI, yeah, what we know that the estrogen and progesterone is low, and FSH and LH is high. That characterize this patient is having POI. Boleh kah? Okay, back to the case summary. Can I see it again? All right. Okay. I think aside from that, you also can say that normal X-ray for the skull to exclude what? What do you think the X-ray for the skull is for?
Pituitary tumor.
Brain tumor.
Exactly. So normal X-ray for the skull, this exclude pituitary tumor, okay, or rule out the pituitary tumor. What else? Negative pregnancy test, okay, fine, understandable. What are the assessment that is also important that you need to mention here? You see, amenorrhea could be due to pituitary tumor, so you conduct the X-ray skull. What else? What are the tests that actually you can exclude here?
I think maybe we could put the TSH, T3, and T4.
Lovely, you get a point. And what is the whole purpose is? So you say that thyroid level test is also conducted, but show normal level that exclude what? Thyroid disease. Boleh kah?
Boleh.
Okay, so skull X-ray. What else? That also rule out cases that is actually associated with amenorrhea.
Maybe pregnancy test.
Yeah, pregnancy test, but you have already mentioned negative pregnancy test, so it's not pregnant, which actually is in there. So for me, I think very good case summary. You have done a good job actually. It's just that I'm trying to help.
Prolactin.
Yes, that is very important. That is to exclude this patient have hyperprolactinemia. So this patient does not have prolactinemia. Okay, so that is the thing in your case summary is that when the doctor, the medical officer see your chart and read your case summary and actually know that you have done this test to exclude this certain differential diagnosis. And I think you have done a very thorough investigation. Yeah, all right. Okay, so so I hope that you know what to be in your case summary. Yeah? And remember, case summary. There's a thing that I need to highlight is that what pointed you to actually diagnose this patient as having POI is amenorrhea. Low estrogen and progesterone and high elevated what you call it, pituitary hormone, the gonadotrophic hormones. Yeah. What else? And the age is less than 40. Yeah. All right. Okay. Actually, I done the learning issue with the POI already. So let's go into the learning issue of causes of amenorrhea, primary and secondary. So primary amenorrhea and secondary amenorrhea.
Okay. So I'm supposed to share my screen, right? Share my screen. Okay. Can you guys see my screen?
Yes. Yes.
Okay. This is so awkward. All right. So boleh nampak kan the
Yes, I see the whiteboard already.
All right. So based on the learning issue, so we're going to see the causes of amenorrhea. So as we know, amenorrhea, there's two types, I would say. The primary and then the secondary. So for the primary, firstly, we have to know what is primary amenorrhea and what is secondary amenorrhea. So for primary amenorrhea is basically when there is no, when the person does not reach their menarche by the age of 14, and this person does not have secondary sexual characteristics yet. So pretty much if it's like by 14 years old and there's no secondary characteristics. And also if this person is like 16 years old, she has not attained her menarche yet, but she has secondary sexual characteristics. So that's for primary. For secondary amenorrhea is when a woman does not have menses for 3 cycles consecutively, and for this person, the period before this are regular period, or this woman has uh, not have her menses for 6 months, but irregularly. Okay, so that's the definition, I would say. So causes of primary amenorrhea. I'm so sorry for the very photo handwriting. So we can see from ovarian side or ovarian etiology, they said, and then we also have central, where it involves hypothalamic and also pituitary, and also abnormalities of the receptors and also enzymes. But I would try to focus a little bit more on the ovarian etiology and central, since it's more closer to us. So firstly, under ovarian etiology, we have something called gonadal dysgenesis. So gonadal dysgenesis is a condition when your ovary is prematurely depleted of follicles and oocytes. Therefore, you will have premature failure of ovaries and you won't attain your menarche. So that's for gonadal dysgenesis. And under ovarian etiology, the second thing, we also have Turner syndrome. Quite not quite common. I mean, quite it's something that we know. So Turner syndrome is basically when ovaries is replaced by scar tissue. So you will have low production of estrogen, which does not make you attain your first period. And also you can have genetical problems like the failure for your reproductive organs to form during fetal development, and also the failure for the organs to function. So that's under ovarian etiology. So for central, we have either hypothalamic and also pituitary. Okay, so for hypothalamic, it can be functional or it can be congenital. So functional is basically when you have an eating disorder or you have weight loss and stress, which makes you by the age of 14 or 16 not being able to get your period. So besides that, congenital pula is basically like Kalman syndrome, and it's like it, and this all of this happens when you were small, so it affects you by your when your age is like 14 and 16. So next, in pituitary, you can have problems such as tumor or hypothyroidism and radiation. So it will affect your pituitary, which causes you to get primary amenorrhea. So other abnormalities can be seen under receptor abnormalities or enzyme deficiencies. So that's for the primary causes of primary amenorrhea. So for the secondary, which is basically what we are seeing today, secondary, as I said, when you miss 3 cycles, when your cycles before this were regular, or 6 months with no period when it was previously irregular. So under secondary, you can also have under ovarian, a problem with your ovaries, a problem with hypothalamus, a problem with pituitary, and a problem with outflow. So under ovarian, you can see there's a problem when you check their FSH first. It's either a normal FSH or high FSH. So if it's a normal of FSH, you are usually diagnosed to have PCOS, as we discussed last week. Okay, PCOS is when you have normal FSH, but when you have high FSH, it can mean you have menopause or premature ovarian failure. Okay. And then if under hypothalamus, you can also have the functional hypothalamic problems, or you can also have infiltrative lesions such as lymphoma and sarcoidosis. Okay, then pituitary, we can see under high prolactin or others. Okay, so if there's high prolactin, it can be from pituitary adenoma, prolactinoma, or there's a damage at the hypothalamic pituitary stalk caused by tumor or trauma. And then besides that, for the others, you can see under radiation, infection, or lesions on your pituitary gland. All right. And then under outflow, you will have something called Asherman syndrome, which was quite something that they actually explained in the internet, whereby Asherman syndrome is when you have uterine disease due to the scarring of your uterine lining, and it usually happens following an instrumentation procedure such as DNC. Yes. So that is pretty much the causes of.
Okay, hold on to this. Don't move away. Okay. Okay. Let me see. Ovarian. Okay, you causes. Secondary amenorrhea. Right. Let me see. Okay. The outflow Asherman syndrome, and yes, you have explained that it's actually damage to the uterine lining. Very good. What is another one that is a cause of obstruction of the outflow tract?
Is it the cervical stenosis?
Cervical stenosis, yeah, which yeah, you did not mention just now. Okay, so structural changes, there are two, Asherman syndrome and cervical stenosis. Very good. Okay, now aside from that, just a bit on what is the common normal physiological cause for secondary amenorrhea?
Pregnancy.
Pregnancy. What else?
Breastfeeding. If
lactation, yeah, breastfeeding or lactation, very good, and menopause. These three are common. Yeah, common cause of amenorrhea, secondary amenorrhea. Okay, good. What else? Okay, this time we talk about pituitary. All right, you did mention prolactin hormone. Yeah. There's also another, which is when you say other, what would that be?
Under pituitary, is it?
Yes, yes.
I would say it will be radiation, or infection to the pituitary gland. And also there's this syndrome called Sheehan syndrome.
Okay, Sheehan syndrome due to low blood, what you call it, during the give birth, right? No, there's a less of blood into the body, is it?
Yeah, lack of oxygen.
Yeah, that's right. I have to recall. Okay, there's another one that is missing here, which is related to your lab investigation of this case as well. The thyroid hormone, the thyroid dysfunction.
Yeah.
Right? So that is also important. Yeah. All right. Apa lagi? Oh, okay. Suppression on the what you call it, pituitary glands. That would be the apa ya tadi? Adenoma. Yes. Did you mention adenoma is a cause of secondary?
No, I did not mention.
Yeah. But are you aware of it?
I was just I couldn't find it in the web.
That is the reason why they're actually doing the skull X-ray, isn't it? To exclude the macroadenoma case, isn't it? The tumor, right? Okay.
Yeah.
All right. So everyone happy with this? A very good presentation. Yeah. So All right, so I think I have touched on that. I also touched about the common physiological cause for secondary amenorrhea. Also, you have covered the causes in the ovarian, hypothalamus, pituitary, and outflow. Outflow, remember, yeah, Ashman and cervical stenosis. Okay, lovely. Now, then we know that there is abnormality on the hormones that is related to the what you call it, the estrogen, progesterone, and also LH and FSH. So before we go into the abnormalities, can we look into the normal menstrual cycle?
Yes, miss. I will share my screen.
All right, lovely.
Can everyone see my screen?
Perhaps take some time, I guess.
Can everyone see my screen?
Yes, it's not a whiteboard, but it's a blackboard. But I can see it.
Yeah. Okay. So normal menstrual cycle, we know that when we start our period at early puberty, which is menarche, it is the start of our menstrual cycle, which pause during pregnancy and eventually stop during menopause. Sorry about my handwriting.
Tak apa. Remember, you're not doing for me. You're doing for all of us here so that you all can score in exam. And not just examination oriented, but also to understand the case better.
All right. So on an average normal menstrual cycle, it would take around 28 days. So in this menstrual cycle, there's two phases that will undergo by the ovarian. First, the follicular phase and the luteal phase. The follicular will take from day 1 to 14, 14 being the ovulation, and luteal is the last 14 days basically, or depending on your cycle, it could take until the 30th day. So during follicular phase,
There are two phases. Which one actually variation in the days?
the luteal phase.
Luteal phase aku tak ingat sangat dah. Okay, never mind.
Okay, so the follicular phase, it happens when the hypothalamus secretes GnRH to the gonadotroph of pituitary and stimulate to produce FSH and LH to the ovaries. This would then stimulate the growth and maturation of follicle. Yeah, basically your follicles will start to mature until at one point it will cause the negative feedback to the pituitary. It will cause a negative feedback to the pituitary.
What is a secretion from the ovary that produce a negative feedback?
The estrogen, estrogen produced by the follicles.
Right.
Follicles will produce estrogen. And then we'll, like I said, we'll give a negative feedback to the pituitary, and then pituitary will stop the release of FSH. This will then cause the follicles. It will cause the follicles
It's confusing. Okay. Cause the follicles to stop growing until eventually only one dominant follicle remain. This one dominant follicle is basically the only follicle with more with more FSH receptors, so that it can, even though there's low FSH, it can still like receive FSH. Then it will become the dominant.
Okay, lovely. Aside from what I call it estrogen as the negative feedback, what other hormone that also work as a negative feedback? That is also produced from the ovary. Start with an I.
Inhibin.
Yeah, inhibin. Actually, inhibin is secreted by what type of cells?
The granulosa.
Okay, granulosa is secrete inhibin, and it actually act negative feedback to inhibit secretion of FSH and as well as gonadotropin releasing hormone. Yeah. Okay, that's good. What else?
Okay, so once the dominant like follicle start to produce more estrogen,
Right.
it will then give a positive feedback to the pituitary and will cause the pituitary to have a surge of FSH.
So that will be positive feedback, isn't it?
Yes, at few days before ovulation. So this will cause the ovulation to happen, where the follicle in the ovaries, it will like rupture and release the oocyte into the fallopian tube, like that. It will, yeah.
Okay, good.
So once the oocyte into the fallopian, during all of this, the endometrium will go and undergo menstrual phase. Basically, your endometrium lining from the previous cycle will shed, and you get your menstrual period. And usually people will have it 5 days, but sometimes it could be more. After that, it will after this bleeding happen, it will undergo proliferative phase, where in response to high estrogen, it will basically thickens and basically becomes
Okay, sorry. I'm trying to get back to you. Okay, ovulation occurs, isn't it? There is uterine cycle. Sorry, ovarian cycle.
Yes, this one is the
Okay, during the ovarian, what happened to the endometrium?
It will basically first it will shed.
Shading. If you look at the graph or the picture, if when the ovulation, I mean the egg is released, right? What happened? Is it shading, or is actually proliferating? Begin to proliferate.
During ovulation, it will.
Now we are looking at the two cycle. What you call it? In parallel. Yeah. So we are actually looking is that during the ovarian cycle, the follicle phase is where we see that the follicle grow. Yeah. And then on the day 14. The egg is released, so that is during the ovulation process. Yeah, you explained this very clearly. Now during the ovulation, yeah, what happened to the uterine layers? Are they very thin, or they're actually growing?
They're growing and becoming like thick. because
Exactly, because can you able to explain why there's a proliferation of the uterine layers?
because when the follicle like produce, it will start to release
You're saying just now back to the okay. We try to focus, yeah. Okay. The so the egg is released, yeah, from the ovary during the ovulation. Yeah. Okay. So what is the condition during the ovulation? What is the condition of the uterine? Is it shading or is actually building up?
it's building up because um because the estrogen is like making the endometrium like thicken and proliferate.
You think estrogen have a role in proliferation of the? Hold on, yeah, let me check. Okay, yeah, is actually the what is the effect of estrogen on the uterine layer?
Can I help, doctor?
Yes, yes. Again, yeah, all the teamwork will be good.
Estrogen actually it helps with the growth of the myometrium, while
Right.
progesterone is more of the endometrium.
All right, good. So, so just now you're talking about ovulation, and then you move on to the story of the intermediate is shading. So a bit of mismatch of the story. So I actually wanted to bring into focus is that once it's ovulation, so the remaining of the follicle cell would become corpus luteum, and they secrete both estrogen and progesterone, but more of the progesterone, right? So the story back is that the uterine layer is actually building up, and what are the changes of the uterine during the availability of this hormone estrogen progesterone from the follicle from the corpus luteum. So just now you're saying about estrogen is what endometrium or which layer? I put that in.
Estrogen is for the myometrium, and then
Okay.
the progesterone is for the endometrium.
Okay, so we conclude that during that phase is actually our uterine is actually building up. Okay, all right. Okay, move on. Lepas tu apa cerita? In the
Miss,
normal.
wait, are you saying that during the once the when the uterine lining is like thickens and proliferate, it's when the ovulation already happened?
Yeah, yeah. Okay, hold on, yeah. When okay, I have, all right. Hold on, yeah. I'll try to bring it because you need the uterine and ovarian cycle to be actually seeing it as a parallel event instead of separate event. Yeah. Mana gambarnya? Okay, sekejap Aku tengah cari untuk. Okay, okay, sekejap ya. I'm using from another computer, yeah.
I think, during follicular phase. Sorry. Right.
Yeah, because I dah open another, that's why it's echoing. Alright, what apa dia?
Since estrogen also involved in like the stimulation of myometrium, so actually during the follicular phase itself, the uterine wall starts to thickens, but it starts to thickens more after the ovulation. But actually the uterine wall starts to thicken before ovulation because
Betul.
estrogen already stimulates the myometrium punya growth.
Okay, betul. You're right. Right at the point. Because just now I had to correct you is because when you say that you say you tell the story of ovulation and then you talk about menstrual shading, which does not match. Boleh kah? Faham kah?
Understand, Miss?
Alright, okay. So tak payah tunjuk gambar lah because I actually want to show the picture of the ovarian cycle and the menstrual cycle together. Alright. Dah habis ke yang pasal menstrual cycle ni?
The last phase.
Alright. Please proceed.
Which is the luteal phase. Basically, when the ovarian follicle, when the oocyte is released by the ovarian follicle, the remaining is called corpus luteum. This will then work together to release progesterone and estrogen, but then progesterone will then be released more, then will stimulate the uterus to go through secretory phase. Like Rania said, it will stimulate the endometrium to basically proliferate and
Sorry. Sorry, yang minta maaf. Just now you're saying about the shading is due to what?
due to the old endometrium lining shedding from previous cycle.
What caused the shading of the endometrium lining? Yeah.
When there's no fertilization,
And
basically the corpus luteum will be replaced by corpus albicans.
okay,
Is
so
the-
corpus luteum decay into become corpus albicans. So there's a drop on the hormones estrogen, and most importantly is a progesterone, because progesterone is the one that caused the proliferation of the endolining cells. Yeah. All right, so that's the end of the menstrual cycle. Okay, can someone be specific on what is the effect of estrogen on the uterine lining, uterine layers, and also what is what is the progesterone effect on the uterus? I think there's one learning issue on the what you call it, explain the function of the hormones, isn't it? Can someone explain the effect of estrogen on the uterus and the effect of progesterone on the uterus? I think this there's one of it is on the learning issue.
Yeah, Jolie is the one who is doing that question.
Okay, all right. Perhaps Jolie can help to address this, because there's one on discuss the source, synthesis, physiological role, and estrogen and progesterone. Just now when who is Pakis? Damia, you are presenting on the uterine and the menstrual cycle. We did talk about is that when after ovulation, egg is released. So what left is actually the corpus luteum. So the remaining follicle cells become corpus luteum and is secrete estrogen and progesterone, where progesterone hormone is much higher, yeah, than the estrogen. But we also wanted to look into is that what is the effect of estrogen and progesterone on the uterus, yeah. And mind you that when this estrogen progesterone are secreted by the corpus luteum, there's no shading of the uterine lining, yeah. So the thing is that the question is that what is the effect of the estrogen and progesterone is the same, or they actually have a separate function on effect on the uterus?
Can you repeat that question? Miss?
Who is speaking? I cannot hear you.
Jolie, Miss.
Oh, Jolie. Okay, Jolie, can you be louder? Because again, I have to remind you that I'm actually not young. I'm actually over 40. So yeah, hearing wise a bit affected. So please help me to speak louder.
Miss, can you repeat that question regarding the estrogen progesterone?
Okay, all right. So I think Damia just explained to us what happened during the uterine cycle and also in the menstrual cycle. Now, sorry, uterine cycle, the ovarian cycle and the menstrual cycle, also known as the uterine cycle. Now, we did talk about is that during the ovulation, what happened is that the egg is released to the fallopian tube, and we see is that the growth of the uterine lining. But my question is, after ovulation, the follicle cells become corpus luteum, and what are hormones are being produced by the corpus luteum is the estrogen and progesterone, where progesterone is much higher than estrogen. So my question is that what is the effect of estrogen on the uterine compared to the progesterone effect on the uterine? Are they having the same, giving the same effect, or they have a different role affecting the uterine?
Okay. Uh, I, I can't share my screen at the moment. I don't know how to draw out the thing, but for
You can type.
estrogen,
You can type.
I can type.
Oh, yeah, you can type using whatever means, Microsoft Word ke,
Okay.
and then you can just type the word and then arrow ya, like in the concept map pun boleh. Tak payah long sentence. Concept map macam tu pun boleh.
Concept map. This is my first time sharing screen, so.
Yeah, never mind. Everything is first time. Since the epidemic, everything is actually there's no kata rigid sangat lah. As long as to express what your knowledge and your concept that you know. Kalau tak boleh draw, tak apa, guna Microsoft Word, type je Word and then type as we go, and then most important is that you can share the correct concept.
Miss, can you see anything?
Yeah, yes, please enlarge your screen.
Enlarge my screen. Okay. No, wait, that's
Okay, bagus. Yap. Okay.
So the question was the effect of estrogen and progesterone on the
Uterus.
On the
Yes,
uterus.
yes. On the uterus. So are the effect of estrogen and progesterone the same on the uterus, or the different effect?
How do I say? The effects of estrogen and progesterone on the uterus. Right. I just so sorry, Miss. So, based on what I searched for, estrogen is meant for is needed for the development of the uterus during the fetal stage, if I remember. Is that correct, Miss?
Okay, yes, we know that estrogen is involved in the development of the uterine lining. But can you tell me what is the changes in the uterus that is affected by uterus? Affected by estrogen.
Estrogen, if I remember, hold on, Miss, I needed to refer back to the notes.
Yeah. Just refer to the notes.
Where is it? Right. Estrogen is to stimulate growth of uterine muscle and development of endometrial lining. But I think it's mostly for uterine, the myometrium, like what Rania said.
Itu je.
Hold on. I can't see the other tabs. And then for progesterone, it stimulates the it stimulates and maintains the endometrial lining, especially for
About the stimulate growth of the uterine muscles. This from the textbook, is it?
Yes, Miss.
Alright, okay. I trust you. Kalau soalan kat exam ni, kalau buat macam ni, kalau salah, don't blame me. Alright. I actually for me is that I expecting answer like there is like whatever I'm expecting something like what you call it, the development of the glands, the vascularization, apa ya, something like that. There's a changes in the uterus, perforation of the blood vessels, proliferation of the endometrial glands, glycogen, deposition of glycogen and fats, something like that. Do you get what I mean?
I think so, miss, but I couldn't find like the ones that I found was their functions in general, but not so detailed when it comes to the uterus.
Okay, so you have that in mind is that how does the effect differ, yeah, estrogen and progesterone on the uterus, because they are not the same, yeah, all right. So, for example, here is the effect of progesterone on the uterus is progesterone promotes secretory activity during the secretory phase of the menstrual cycle, and that is to prepare for implantation of the fertilized ovum. Yeah, so you find out which hormone cause the deposition of glycogen and fat onto the what you call it, the uterus. You also have to find out is that the proliferation and dilation of the blood vessels, so that more blood, yeah, so more nutrient to the to feed into to the to provide to the uterine cells. Now, these are the effect that we actually that which I'm actually looking at. Yeah. All right. I think we do have much time. Okay. Can someone explain on the synthesis of the estrogen?
Synthesis on what? Miss?
Estrogen hormone.
Overall,
Synthesis.
like the sources and everything.
What do you mean resources?
No, the like the sources and then how it's
Yes. How is the what you call it, estrogen is being synthesized, and normally where?
okay. The estrogen is synthesized by both. Okay, first the wait, hold on. Let
What is
me
the precursors substrate to use to synthesize estrogen?
cholesterol,
Okay, all right.
which is then converted into pregnenolone,
All right, very
and
good.
it's then turned into an androgen in the theca cell, which is stimulated by luteinizing hormone, which then is transported to the granulosa cell, which is stimulated by the FSH to turn.
Okay, what substrate is actually transported into granulosa cells?
Dehydroepiandrosterone.
Androstenedione, is it?
Yes.
All right. Why that androstenedione has to be transported from theca cell to granulosa cells?
Because granulosa cells have the component aromatase to convert it to estradiol and estrogen.
All right.
Like forms of estrogen.
Right. Okay. Aside, we know that large quantity is actually produced from the granulosa cells. There are also a small quantity of estrogen is also secreted by what organ?
Can you repeat that, miss?
A large quantity come from the granulosa cells. So, which other organ or tissue that also secrete estrogen?
Is it the adipose tissues of the adrenal cortex, miss?
Adrenal cortex, yes. Another?
Is it the mesenchymal cells of the adipose tissues?
Another is during when what you call it, in the pregnant woman, the estrogen is produced from where?
First, in the first 6 weeks, it's produced by the corpus luteum.
Yeah.
And then after 6 weeks, it's produced by the placenta.
Okay, so there are, aside from estrogen produced by granulosa cells, some are also secreted by adrenal cortex, and in the case of pregnant woman, yeah, is also secreted by the placenta. Okay, very good, everyone. Good job. Yeah. Okay. So what else? else? Okay, just very briefly tell me is that the hormone estrogen act on what type of tissue? The estrogen has an effect on what's the effect of the estrogen? What the cells that have the estrogen receptor?
Your breast,
All right, breast. What else?
your cervix,
My cervix. Okay, boleh.
and then your pelvic as well, I think.
Sekejap So effect on breast very good. Pelvis. Okay, yeah. Sekejap. Pelvis ni effect on cervix. Pelvis. Okay. I think I'm confused with progesterone pula. Okay. Pelvic. Okay. Secondary sexual characteristics. Yeah. Pelvis. Betul. Effect of progesterone. That is we consider pelvic is one of the secondary sexual characteristic. Apa lagi tadi? Breast. Someone say breast. Pelvis. What else did I miss?
I mentioned cervix.
Cervical. Cervical is actually under progesterone. Progesterone increase thickness of cervical mucosa, so it inhibits the transport of sperm into the uterus. Yeah, that is where in our what you call it contraceptive pills they have this progesterone also in the contraceptive pill, and actually the function is actually similar to that. Yeah, inhibit transport of sperm into uterus. I'm not sure about estrogen effect on the cervix. Apa lagi? We are looking into the effect of the estrogen on what other tissue?
Bones?
Huh?
Bones?
Sorry, I cannot hear you, Jolly. Can you speak louder?
Bones?
Bones. Okay, lovely. Yeah, all right. So that's why it's prevent osteoporosis. Okay, apa lagi? What else?
Endometrium.
Endometrium. All right. Tadi we that means the uterus. Apa lagi? Does estrogen have an effect?
Blood vessel
Blood vessel ada is actually
for vasodilation, right?
Yes. That's why more nutrient delivered to the endometrium. Bagus. Okay. Ada tak? Is there any effect of estrogen on the ovarian follicle?
I think yes. The
Yes.
ovarian stromal cells.
All right. So estrogen has effect on ovarian follicle, uterus. What do you think? Is there any effect of estrogen on the fallopian tube? If yes, how?
Based on the internet, it says estrogen act on the receptors that stimulate the tubal motility.
All right. So it's like increased activity of the cilia, isn't it? All right. I think I'm skip that. I hope that you actually look into. Actually, there are more. I cannot scrutinize all, but you can read on the function of the estrogen and progesterone. Now, can I have the sign and symptom? Explain the pathophysiology of the sign and symptom, which is actually very important.
It's my part, Miss.
Yes, please. Actually, I want to finish at 5, but I try my best.
All right. I'll try to share the screen for a while.
Okay. After the pathophysiology changes, yeah. Next is also explain the relationship with between galactorrhea and amenorrhea, and relationship between hirsutism and amenorrhea. Siapa yang look into it nanti Please prepare yourself, yeah.
Can Miss see my screen? Can
Yes,
everyone
yes.
see my screen?
Boleh,
All
boleh.
right.
So what are the signs and
If,
symptoms experienced in this lady, yeah?
Hello.
Yes, yes.
So basically, she experienced headache, poor sleep, hot flashes, night sweats, dyspareunia, and low back pain.
Right. Wasomoto?
Sorry, where is it?
Wasomoto. Is it not in your...
Wasom-
let me see your progress, yeah. Apa ya? Make sure that's Wasomoto. I thought there's Wasomoto as well. Jap. I'll look into your progress. Okay,
Hello.
yeah. Yes. Okay. Hot flash, night sweat, these are Wasomoto, yeah, symptoms. Headache, poor sleep. Okay, hot flash and night sweat is also called Wasomoto symptoms, yeah. Wasomoto
Hot flash.
symptoms, yeah. Okay, low back pain and dyspareunia. Alright, so these are the signs and symptoms and weight gain. Alright, okay, itu je. Alright, please explain the pathophysiology. Who's presenting? I'm not hearing anything.
I think she's having internet connection problem.
I see. Okay. So, macam mana?
Hello.
Yes, you are back.
Sorry, Miss. My
Tak apa.
internet
I ingatkan
is.
I punya laptop yang problem sudah frozen pula.
No. It's my internet. It's quite
Okay,
bad.
tak apa. Please resume back. So I was like, what happened to my laptop? Okay, good to have you back.
All right.
Okay.
All right.
Please
Okay.
proceed.
So should I explain the pathophysiology now?
Yeah, sebab, okay, one more thing to all of you, please pay attention on the pathophysiology. This is a very, kata favorite punya question dalam exam tau. I tak tahu pasti ni, sebab I think you have 2 PPL, right? 2 cases, right?
Yes, I think so.
Yeah, all right. So anyhow, this is important. Pay attention on that.
All right. So let's start with the headache. So how does the headache occur is when because this patient, she has POI and premature menopause. So when she has this, the hormones are not stable inside her body, mainly estrogen and progesterone. So in this case, her estrogen. Sorry, Miss. So so estrogen decreases, and this will also cause progesterone to decrease because of the hormone fluctuation, hormone imbalance in the body. So because of this, low progesterone and low estrogen, the blood vessel will constantly expand and contract. Why does the blood vessel constantly contract and expands? Is because the estrogen, one of the function of the estrogen is to cause blood vessel dilation. And the progesterone is the cause for the contraction of the blood vessel. So therefore, there will be constant contraction and expansion of the blood vessel. So because of this constant contraction and expansion, this will cause pressure changes in the pressure changes in the body, and this will cause irritation to the meninges. And therefore, the irritation will be detected by the pain receptors and will cause headache. Okay, all right. Okay, so that's for headache. So number 2 is weight gain. So in normal phase, so during puberty till the perimenopause phase, or in normal women, um, the woman will store fat in hips and thigh, and we have normal estrogen. So estrogen, one of it is for fat deposition. It's for fat deposition. But in this case, she has low estrogen because of the POI. So because of this, there will be a low metabolic rate, and this will lead to fat storage because the function of the estrogen, as I said, is for fat deposition and also metabolic rate. So low estrogen will lead to low metabolic rate and fat storage. Sorry for the bad handwriting, by the way. And because of the fat storage, this will cause weight gain, especially in the visceral area. All right. So next, I will explain about the hot flashes. Okay, so according to what I researched already about this, so because of the hormone imbalance in the body, mainly progesterone and what's it called? Estrogen, this will lead to other hormones to be imbalanced as well, such as the one that regulates the temperature, which is the thyroid. So this will affect. Sorry, let me write. Affect the hormone that regulates temperature. Thyroid. So this will cause the vasomotor symptoms to show.
Okay, hormone imbalance. Okay, in this patient,
Mm-hmm.
I don't think that there's a hormone imbalance that regarding to the thyroid hormone. Thyroid hormone's level is normal, isn't it?
Yes. Yes, miss. So I'm quite confused in this as well, but this is this is what I found for the general explanation. I'm not quite sure how to
Okay, can you scroll up a
relate
bit,
it.
Teddy? Can you scroll up? Scroll up a bit.
Scroll up where?
All right. Okay. Okay.
All right.
The first one is actually you're showing the headache. Yeah.
Yeah.
From my finding is actually is
Mm-hmm.
that headache is due to not do not have a proper sleep because of the vasomotor symptoms. No night flush and all that state. That's why
All right, all right.
have this depression, anxiety, no mood swing because and giving headache is due to the vasomotor symptoms. And we are talking about when we talk about vasomotor symptom is actually the hot flush and the night sweat. Yeah. All right. Okay. Don't worry. I want to show you something.
Mm-hmm.
Okay, I upload the file. Sekejap.
So should I close the screen?
Jangan close. Nanti
Oh.
you sambung sebab sign symptom tak habis lagi untuk
Okay,
present.
okay.
I'm trying to support you so that
Mm-hmm.
nanti kalau final exam keluar ni, you tahu apa untuk cerita lah ya. Okay,
Alright.
okay, hold on. I'm trying to find the file. Okay. Sekejap I want to show you this one. Okay, sekejap. All right. Okay. Can you see this? So, okay, I want to show you here is that why having the vasomotor symptoms. You notice here is that our temperature are actually this for normal human being, we will normally have a normal regulation of the body temperature, betul tak? And they
Betul,
actually oscillate in a certain range. Yeah. So what happened is that there is no solid evidence on that estrogen affected this, but based on a study, they say that when they deliver when they give treatment in form of estrogen, the kind like they actually widening this thermal regulatory zone. So they actually lessen the vasomotor symptoms. So we over here, if you look over here, there's this threshold, upper and lower. So your body temperature will oscillate. Yeah. All right. So and when what I call it, when the onset of the menopause, yeah. So estrogen is lacking. What happened is that your thermoregulatory zone is actually narrow. All right. So that's why when it goes up, you will have experience hot flush, and then also shivering when it's actually deep down. Yeah. So and evidence show that women, yeah, that is that reach menopause, they will have dysfunctional temperature regulation, and because of the narrowing of the thermoregulatory zone. So as I say is that when these women given estrogen, they widening the zone and they reduce these symptoms, well, the vasomotor symptoms. You're clear?
Yes, miss.
All right. Okay. Can you
So,
please?
so basically, it's just because of the narrowing of the thermoregulatory zone, is it?
Yes. So over here is that they're saying that that's why it's like there's they heat dissipation, yeah. So it's a certain flush, you know, the dilation of the blood vessel. So that's where they have this hot flush, because the maintenance of the temperature regulation is actually not as smooth as before pre-menopause.
All right.
All right. So what else? Apa nak? I actually this is actually taken from journal. Yeah. This, the journal. Hold on. I can. Um, you can actually Google. Hold on. Can someone take over this? Sekejap, ya. All right. So you can actually find Google Scholar or whatever. The title of this paper is, because it's from my another computer, yeah. So tak tahu macam mana. I give you the title. You look for it. The of the motor symptoms that occur in perimenopause, menopause, and postmenopause life stages. I think it's a very long title. Boleh kah? Just Google this term lah. Okay.
All right.
Okay. Sambung balik. So vasomotor symptoms included the hot flush and the night sweat, and headache is because it does not have a proper sleep. Yeah.
All right.
Because it's the hot night sweat is actually interrupting is having the patient will have a difficult in sleeping.
Okay, so the headache is because of the proper sleep, and the weight gain is as I've explained just now. So the hot flashes is due to the narrowing of thermoregulatory zone that is affected by the low estrogen. Is it correct, Miss?
Affected by estrogen, not solid. There's no solid evidence, but treating it have lessened the symptom.
treating it with estrogen, is it?
Yes, yes.
All right, all right. So, I'll continue with the easily irritated and depressed.
Easily irritated and depressed is also due to this the subsequent effect of the lacking of
Lack of
sleeping.
sleep.
Yeah,
Yeah.
yeah. All right. What else? The backache, please, is also very important.
Okay, the back pain. All right. So next, the low back pain. Again, due to one of the function of the estrogen is to help increase activity for activating the vitamin D. So in this patient, since she has POI, she has low estrogen levels, right? So low estrogen levels would um, would decrease the activity in activating vitamin D. So therefore, it will have vitamin D deficiency.
We are not talking about bone ache. Yeah, we are talking about back pain,
Uh,
backache.
isn't it because of the degenerative disc and that will cause the low back pain? I have two explanations, but I'm not sure which one is the more correct one.
It's nothing to do with vitamin D. Vitamin
All right.
D is more to osteoporosis.
Okay. All right. All right. So then I'll continue with the second is the second pathophysiology. So the estrogen helps to maintain the tissue which contains collagen that contains in the invertebral disc. So the low estrogen will cause severe lumbar degeneration and causes low back pain. That's according to my findings, Miss.
If that happened, that will happen to men as well. Okay, backache is actually more to the laxity of the uterine ligament.
Less elasticity.
Laxity, laxity of the uterine ligament.
All right.
And that's where is a very common symptoms where the woman with postmenopause will also have a uterine prolapse, yeah, and the pain is due to the pulling of the ligament.
Okay.
So bukan yang tadi, ya. So you
All
probably
right.
have
All
to
right.
correct the
The
pathophysiology,
pathophysiology.
yeah,
All right. All
of
right.
the backache.
All right, Miss.
All right. How about hypertension that experienced by this patient?
Hypertension.
Kan, this patient have hypertension, kan?
Yes.
Apa cerita pula pathophysiology dia?
Oh my.
Is it just because low estrogen, it means that lesser vasodilation?
Yeah. Yeah. You know that, right? Estrogen have if it's a long term, it would actually lead to cardiovascular disease. Yeah. So what happens is estrogen is kind of have a protective role on the blood vessel. So it make more the blood vessel to be more flexible. So there are estrogen receptor that is on the inner layer of the artery wall. So it help the blood vessel to be flexible so that they can easily dilate, yeah, to accommodate the blood flow. So lacking of this estrogen means what you call it, that would affect, yeah, the dilation of the blood vessel. Boleh kah? Betul kah? Correct? Okay, I don't have much time. I actually emphasize the important point there. Okay, what about relationship between galactorrhea and amenorrhea? Can someone explain? And the relationship between hirsutism and amenorrhea?
Yes, Miss. Yeah. Can you guys see the screen?
Baru boleh nampak. Bagus,
Okay.
bagus.
So for the hirsutism, let's go for hirsutism first. It is a condition when the woman has the excessive growth of the hair, and it is because of the high androgen level and the testosterone. Okay, but in this patient, she does not have any hirsutism because there is no evaluation of the androgen and testosterone. And in the physical examination, it mentioned that she has not have any hirsutism.
All
Okay,
right.
so
Can you explain the relationship how uh, uh, hirsutism relate to amenorrhea? What is the relationship between hirsutism and amenorrhea?
amenorrhea.
How hirsutism can cause can actually patient with hirsutism will also have amenorrhea. How can you explain this relationship?
Can I help?
Yeah, please. Kalau boleh cepat sebab
Sorry.
wanted to finish at 5, but I cannot skip this because this also one of the important learning issue.
Like as I know, usually hirsutism is caused by polycystic ovarian syndrome. This is when your ovarian fails to, or I would say, fails to respond. Then since your, but then there will be increase of LH, and this
Okay,
LH is
wait. All right, let's get this story right. Yeah, hirsutism is actually due to what? Excess hormone.
testosterone.
Okay, testosterone or high androgen, yeah, in excess. Okay, and that we call it hyperandrogenemia. All right, fine. So what would be the effect of having high androgen excess that could lead to amenorrhea? What is the effect of what is the side effect of high level of androgen or high testosterone? Okay, all right, never mind. Okay, yeah.
Is it male secondary characteristic?
Okay, hirsutism is one of signs and symptoms of PCOS, yeah, and that is actually the root cause is having high androgen level. Now, having high androgen level, it will lead to suppression of the hypothalamic pituitary ovarian axis, and that would have an impact on the gonadotropin releasing hormone pulsatility. It disturbs the pulsatility of the gonadotropin releasing hormone, thus and lead to amenorrhea. Okay, can you also explain that for galactorrhea? What is the relationship between galactorrhea and amenorrhea?
For the galactorrhea, it is when the prolactin level is high, and when the prolactin is high, it leads to the hyperprolactinoma, and it will lead to the amenorrhea.
Okay, galactorrhea is due to high prolactin hormone, right? It's known as hyperprolactinemia. So if it's high prolactin in the blood, what will be the effect? Does it affect at the hypothalamic level or pituitary level? If there's an effect on the hypothalamus level, so what will be the effect? You can Google it. High prolactin, what will be the effect on at the level of hypothalamus, at the level of pituitary?
It actually inhibits your GnRH.
That is what I'm looking for. Very good. You must
So
tell a
when
story. Yeah.
So when your GnRH is inhibited, then low LH, low FSH, then low estrogen, low progesterone.
Yeah, and
That's
that it will be
amenorrhea.
amenorrhea. Yes, that is what I want to look at. Yeah. So a relationship between galactorrhea and amenorrhea. Once is high, galactorrhea is due to high prolactin level, and prolactin level, the key effect is actually inhibit GnRH at the hypothalamus level. So no GnRH, no LH and FSH, no LH and no LH, no estrogen and progesterone. So that's lead to amenorrhea. Now hirsutism is actually, the key point is your androgen in excess. Androgen affected the hypothalamic pituitary and ovarian axis. So that means that there is no GnRH, there's no LH, no FSH, and no ovarian hormone. So that will be amenorrhea. Boleh? Okay, anatomical changes. Okay, sorry. We did talk about what are the long-term presentation of this patient, short-term and long-term presentation.
If the short term, do you want me to write it down or just?
No need. Just read it out.
Okay, so if short term, like just now, we see the vasomotor, hot flashes, night sweats, poor sleep, and then you will get also sexual dysfunction, dyspareunia, and also vaginal dryness. You can get joint aches, and also psychologically will be the depression, anxiety, irritability, mood swings, and also tiredness. But for the long term, as we know, we can get osteoporosis. It will also leads to CVS diseases. What I found out, it can also lead to myocardial infarction for a certain percentage. And it can also lead to urogenital problems such as lower urinary tract and pelvic floor atrophy, which causes the patient to feel the urgency, nocturia, and also incontinence. And she can also get vaginal atrophy.
All right. Okay. All right. Thank you so much. So I'm done with the long-term presentation of signs and symptoms and long-term presentation. All right. I'm done with that. Okay. Anatomical changes in menopause. Just a brief one. Explain the anatomical changes in menopause, and you can relate some of this in with this case as well. Oh, Shafika, okay, I can see your screen. You can start presenting.
Hello.
Yeah, yes.
Okay. So, because of low estrogen in this patient from the primary ovarian insufficiency, which makes the ovary stop functioning before the age of 40. So, the patient lost estrogen, which the estrogen function is to thicken the vaginal lining and also to promote lubrication in vagina by secreting vaginal secretion. So, without both of these function, the vaginal lining will be thinner, as you can see on the right, and also without the lubrication it will become dry, and this thin and dry vaginal lining will cause the dyspareunia in this patient.
What would be the vaginal pH changes?
pH changes increase.
Okay, so what does that mean? What is the normal vaginal pH? Anyone knows?
Less than 4.5.
So it's acidic, in a normal women. So, but what about the woman with menopause? What would be the any changes to the vaginal pH?
It become less acidic, just as it was before puberty.
Yes, so it's become less acidic. So I think just now we talked about estrogen. Yeah, estrogen affected it helps to reduce the pH of the vagina, so it become more acidic. So it's actually prevent vaginal infection. But with the onset of the menopause, women will have changes in the vaginal pH, and that is where it's susceptible for what you call it, vaginal infection. Yeah. Apa lagi selain daripada what else vagina aside from the changes in anatomical changes in the vagina, is there any more changes from other organ experienced by the menopause woman in general?
Yes.
Yes, doctor, there will be the lack of the breast development, and also there would be
There's
increased
definitely
bone.
there's definitely there'll be no more at the age of this at the menopause age. Definitely there's no more of development of the breast. But what is actually happen in the breast of the of women with menopause? Sagging breast, betul tak? So what do you think? The sagging breast is actually caused by what?
Estrogen.
Is it
Because
due
of the low estrogen.
to the cell destruction?
Sorry? Why women with menopause have sagging breast?
Low estrogen.
Loss of okay. Fine.
loss
Okay. You
adipose.
use loss of, okay. Very good.
Atrophy of the gland.
Sorry. Can you repeat that again?
No, doctor. I said, is it because of the atrophy of the glands?
Atrophy of the glands. All right. Glandular tissue, yeah, have a reduction in the fat, yeah, deposition. Someone say about fat deposition. I will agree. Don't when you explain the changes that occur in the breast of the menopause. We know the estrogen memang there's no estrogen level. What you call it? Insufficient levels of estrogen. But what is the effect of the estrogen on the breast? Without estrogen, that means that what?
The glandular tissue shrinks and the connective tissue decreases, and it is replaced by fat.
For my understanding, breast is actually made of fat tissue. So a woman with menopause actually would have less fat. There's a fat depletion, yeah, in woman with menopause. Not that is that the breast is filled with fat tissue in menopause woman, but much of it is that is lessened. Actually looking is that that the estrogen have an effect on the collagen. So
Less elasticity.
yes, elasticity of what ligament? Which ligament is affected in the breast? You think you can finish at 5? What ligament is affected in the breast? That lead to sagging of the breast.
Is it Cooper's ligament?
Yes, suspensory ligament of the Cooper or the Cooper suspensory ligament. Okay, very good. So we did talk about that in menopause women, so less estrogen level, so loss of collagen in this suspensory ligament Cooper that lead to sagging breast. We also talk the breast is that there will be a fat depression, yeah, less fat tissue in the menopause woman. We talk about collagen is also content is reduced, that's why it causes the skin wrinkle. Aside from breast, skin, what else? What are the changes in menopause? Anatomical changes, yeah, we are talking about. What are the changes that occur that lead to incontinence, urine incontinence?
Uterus.
Hmm?
Uterus.
I cannot hear you.
Uterus.
Uterus. So you think that uterus changes to what? That cause the urine incontinence.
Miss, is it pelvic floor?
Pelvic floor. Okay, hold on. We know that long-term complication is actually the urine incontinence. Yeah, and if I'm not mistaken, it's due to the uterine ligament. It's due to the loosening of the uterine ligament. Anyone disagree or agree?
Agree.
Are you sure?
So, Miss, just have a question. Miss, I have a question.
All right.
Because of the low estrogen, so we have the Cooper's ligament that's being weak, and also the ligament in the urethra is being right.
Mm-hmm.
Okay, that's it. I just want to confirm it.
What else? Itu je ke? Is this the another changes that you observe in menopause woman? Aside from the skin, the breast, uterine ligament?
What about her bone structure?
Bone structure, so it's osteoporosis. Okay, very good. What else?
Doctor, the vaginal dryness.
Yes. So dryness and aside from dryness, what else? So the less lubricant, less secretion. What else? What happened to the epithelial cells? What happened to the vaginal mucosal cells? Any changes? And what about cervix? Any changes, anatomical changes on the cervix in the menopause of woman? Siapa yang buat learning isu ni
There is thinning of the myometrium.
Myometrium? We are not talking about uterus. We are talking about vagina and cervix. We finish up uterus. Let's move on to the cervix. And the vagina. Even uterus, yeah, the changes. What will be the changes in uterus? Yeah, actually we didn't discuss. What is the anatomical changes in the uterus in a menopause woman?
Atrophy?
Atrophy.
Yeah.
So what? So you're saying that the uterus shrink in size.
Yeah.
All right. Aside from that,
Shorten.
what shorten?
The vaginal canal.
Sorry, I hear it broken. I cannot hear.
Shortening of the vaginal canal.
Okay, vaginal canal. All right. So shortening of the vaginal canal. Alright, boleh. Okay, which part of the organ that has this transformation zone in the lining?
Your cervix.
Yeah, cervix. Okay, what is the changes on the transformation zone in the postmenopause woman?
Doctor, is it that we will not be able to differentiate like the transformation from endocervix to ectocervix? It will just be one.
No, it's actually the anatomical changes expected, yeah, in the postmenopause is that it said that the transformation zone is actually move upward and higher. And the other thing is that the endocervical canal, yeah, will be much more narrower, and that is where it leads to cervical stenosis. Just now we did mention cervical stenosis is one of the cause, right, of amenorrhea, isn't it?
Yes.
All right. So the anatomical changes is happen on the cervix is actually where the transformation zone, yeah, actually it move higher and narrower, yeah. So and that's where what you call it, the endocervical canal will become much more narrow and lead to cervical stenosis. All right. What else? What happened to the ovaries in the postmenopause woman?
Smaller?
Shrunken, yeah, smaller, yeah. Okay, I think there's actually many of the organ that we did not touch, but I don't have much time because it's close to 5. All right. Okay. Justify why it's necessary to measure prolactin, thyroid hormones, and scar X-ray. So, just very briefly, why measure prolactin? That is to exclude what case is that?
Hyperprolactinemia.
All right, to exclude the hyperprolactinemia, yeah, that it could be also a cause for amenorrhea. Okay, why measure thyroid hormone?
To exclude thyroid insufficiency.
Hypothyroidism.
All right, to exclude hypo and hyper thyroidism. So if let's say that because hypothyroidism also lead to amenorrhea, but how? So hypothyroidism would actually cause a decreased level of free T3 and T4. Yeah. So in the circulation. So if it's low free T3 and T4, what happened in hypothyroidism?
It increases the TRH.
All right. So increase TRH level, and increase TRH level, what happened?
It will stimulate the release of prolactin, and then it will inhibit your GnRH.
Yes, okay. Increase prolactin secretion. So increase that, then it will inhibit GnRH, so also inhibit LH and FSH. What about hyperthyroidism? So hyperthyroidism also lead to amenorrhea, but what happened is that there will be free T3, T4 in the circulation, and what would that lead to? Okay, one moment, yeah. All right, you see it in skin, right? So we talk about hypothyroidism. All right. So in hypothyroidism, decrease more to free T3/T4. So sorry. So there'll be high TRH. Sorry, just broken English, doesn't matter, but this is a concept map. High TRH and then high prolactin. Yeah, high prolactin. What happened will be inhibit GnRH, then okay, so low LH and FSH. All right. So that is where that will cause amenorrhea. So what about hyperthyroidism?
It increases your sex hormone binding protein.
All right, that is very good. So you have free T3/T4. So there will be high SHBG. So what happened then?
So your estrogen and your progesterone will bind to it and um, will not be functioning towards their target cells.
So what happened is that you have high SHBG, yeah. So the free and so it actually bind to the estradiol, yeah. So they bind to the estradiol. So what happened is if most of the SHBG bound to the estradiol, so there will be less free estradiol. Betul tak?
Betul.
Okay, so what is the consequences of less free estradiol in the circulation? Why having high free estradiol is important in the circulation? So if less free estradiol, apa cerita? What happened?
Is it hypertension just now?
No. Our learning issue is actually why measure prolactin, why measure thyroid hormone. So it's actually related to amenorrhea. So in hyperthyroidism, so you have a free T3 and T4 in the circulation, and that leads to a high production of sex binding globulin secretion from the liver, and having this high SHBG in the circulation, they will tend to bound to the estradiol, and then there will be less free estradiol in the circulation. So what happened?
So there will be no positive feedback to your LH.
All right. So no positive feedback. Yes. So that's will actually inhibits LH surge. So if it's no it inhibit LH surge, that means there's no ovulation. Betul tak?
Betul.
Yeah. So that's why what you call it? That's why we test this thyroid hormone. Okay. What about scar X-ray?
For the pituitary adenoma.
Right, done. Okay. All right, let's go to the I think I want to stop sharing. Okay, let's move on to the next learning issue. Apa yang kita I think management, isn't it? Oh no, lab investigation. Investigation. Okay, what is the important lab investigation that is actually in this case, yeah? What is the laboratory result in this lady? Can you someone highlight the lab investigation that is actually important that that helps you to arrive to that this patient have what we call primary ovarian insufficiency?
Okay, for the lab investigation in this she has high FSH and LH.
Apa lagi?
And low estradiol and progesterone. And also for her pelvic ultrasound, there's no ovarian follicles, and also she has thin endometrium. Other than that is normal.
What is normal?
Her full blood count.
No. What is normal? That helps to exclude the PCOS, the case that is associated with amenorrhea. What is normal?
Her prolactin is normal.
Okay.
TSH, T3 and also T4 is normal.
Okay, thyroid hormone is normal. Apa lagi? I think itu je lah ya. Okay, alright. So about the okay, let me explain the term of primary ovarian insufficiency. Please, your definition of the primary ovarian insufficiency is that the condition had to be characterized by the amenorrhea and then low estrogen level, elevated cholesterol level, and the another thing is that the age is younger than 40 years old. Yeah, there is a proper term of to define the primary ovarian insufficiency. Okay, what else? Okay, what is the possible disease that the lady would have as a progress of a premature menopause? That would be what?
Osteoporosis.
Lagi? What else?
Endothelial dysfunction.
Endothelial dysfunction that is linked to cardiovascular disease. Lagi?
Yeah.
One more.
Is it cancer?
Huh? No,
Is
dear.
it cancer?
Bukan. This is long term. On long term, this time we discussed the long term, isn't it? What else? Osteoporosis, heart disease, one more. What else? Siapa tadi yang present long term and short term tu?
It's the urogenital problems.
And actually the urogenital problem is actually called urine incontinence. All right?
Yes.
Okay, so that is the long term. So that is actually the complication that will be expected. Yeah, complication that will be faced by this lady that in long term. Yeah. All right. Management, please. Lepas management, psychosocial. All right, and then that's all.
Menopause management is my question. Okay.
Management ni, can you include two important things? What is the normal, how to manage this? Yes. What is the benefit of hormone replacement therapy and also the risk of hormone replacement therapy? You have to discuss this both.
The risk is the long-term use.
Okay. Sorry. Yeah. First is how to manage POI. Okay, with hormone replacement therapy. So what type of treatment is in the hormone replacement therapy? And then later on include the benefit and the risk. Boleh? Can?
Yeah.
Okay.
Hormone therapy, estrogen therapy is the most effective, and sometimes the doctors might recommend using progestin too, in addition to estrogen. And some people develop risk of breast cancer or cardiovascular risk after using it for a long time. But yeah, those are the risks
Are you
involved.
sure cardiovascular risk with long-term use of HRT?
Yes.
What type of vascular? What type of cardiovascular problems? Can you please be specific? Specific.
Cardio.
Sorry, cannot hear you. Just now you talk about cardiovascular risk with using the HRT.
Hello. Yeah.
So what is, because cardiovascular disease actually is a lot. Can you be specific?
Heart attack.
Heart attack? Are you sure?
Yes.
Is it hypotension, doctor?
Hypotension.
Maybe because because of the vasodilation.
Wait. You actually contradict to yourself. This patient have not undergoes hormone replacement therapy, but it's actually have hypertension. How can you say that given the patient if follow the HRT will have a heart attack and also hypertension? Does it make sense?
No, because I thought she said for like long-term use of HRT.
Okay, long-term use of HRT this cause heart attack.
No, not heart attack, hypotension. I didn't say heart attack.
Oh, sorry. No, my dear, it's not.
Okay.
All right. Okay, let's go step step by step. All right. What is the normal treatment used in HRT? The patient I will be given what?
Estrogen.
Estrogen. All right. Aside from estrogen, there are cases where patient also given what?
Is it vitamin D? Vitamin D.
Okay. I have to confess is that if you give me the name of the medicine, I do not know. Yeah. But in hormone replacement therapy, how is it? How is what is this in what is given in the HRT?
I give estrogen pills
All right, estrogen pills or
or patches.
estrogen with.
Progesterone.
All right, very good. So, anyone knows that this estrogen in the HRT is actually from what is being synthesized? Where's this estrogen come from? That is given in the HRT.
Is it the urine of horses, the pregnant horses? Is it?
I don't know, but the over in
I
my
read
notes.
somewhere.
But yes, I'm not saying about urine, yeah. But over here is that they say the estrogen is actually from the equine. Estrogen. Equine means horse. I say conjugated equine estrogen. All right. Aside from conjugated equine estrogen, what else? What is the other source that is actually used to synthesize estrogen for HRT?
Doctor, on the net it says from plants as well.
Yes, plants. Do you know which plant?
No, doctor, we don't know.
All right, soya
Doctor,
bean.
it says soybean. Yeah.
Yeah, okay, soybean, plant source, okay. So, and also progestogen, yeah, also synthetically produced from the plant source. All right, let's go through the, I'm not sure whether you need to know the names. If your lecturer expected that you need to give some names of the estrogen and progestogen, make sure that you know the names, yeah. Okay, what is the benefit of HRT and the risk of HRT? What is the benefit of HRT?
Breast cancer risk. I'm sorry, risk or benefit?
Benefit. Sorry, benefit. Let's go step by step. Yeah, benefit of the HRT.
It can
Okay,
help.
so the first one is a reduction in vasomotor symptoms.
Bagus.
So it will reduce the hot flashes and stuff.
Okay, very good.
And then when it helps to balance back the hormonal imbalance, it will improve mood and also reduce the risk of osteoporosis, cardiovascular diseases. So,
Right.
okay.
Okay. So wait. Improve mood. The mood, depression, anxiety, mood swing is actually due to the vasomotor symptoms. If so, once decrease these vasomotor symptoms, the patient will have better sleep and definitely will have a better mood, yeah, and decrease the anxiety. And then you did talk about it reduce the risk of osteoporosis. All right. What else? Aside from vasomotor, decrease vasomotor symptom and the risk of osteoporosis.
Decrease cholesterol, the high density cholesterol.
High density cholesterol. How does it work, eh?
The estrogen will, I think, if I'm not mistaken, estrogen will bind to the HDL and reduce it.
Estrogen can bind to HDL. Are you sure? Betul ke? Sekejap I don't know how. Are you sure that estrogen bind to HDL?
No, doctor, I'm not sure. I'm just I just know
Hey,
that
this is.
estrogen contributes to HDL.
Aduh, sekejap I know that the effect of the estrogen is effect of the estrogen on the metabolism. Sekejap. I don't think that estrogen bind to HDL. I think no.
Doctor, does it help with vaginal dryness?
Right. Yes. So what else? Okay, one more is actually it reduce the risk for colorectal cancer. Yeah, reduce the colorectal cancer. This is actually from the study. Yeah. So again, the benefit of HRT is decrease vasomotor symptoms, decrease urogenital symptoms, urogenic symptoms like urine incontinence as well as what you call it, the dyspareunia, decrease the risk of osteoporosis and also decrease the risk of colorectal cancer. Okay, what is the risk of HRT?
The thromboembolic diseases.
Yes. All right. So when tadi semua say just general vascular apa cardiovascular disease, I don't like it. Yeah. So it actually can reduce thromboembolism, venous thromboembolism. Very good. What else?
It also reduce the risk. Has the risk for breast cancer.
Yeah, it actually. So that's one thing that people are worrying. Yeah, taking HRT is that it actually increase the risk of breast cancer. Apa lagi? What other cancer it can cause?
Endometrial cancer?
Cervical.
And I'm not sure, but endometrial cancer, yes, yeah. And then one more disease that it can actually increase the risk of this disease.
Stroke?
No, my dear. This is you're doing a guessing ayo. In medical field don't go guessing now. Your patient get die. Increase the risk of gallbladder disease. All right. Okay. Last one. Discuss the psychosocial issue that will be experienced by this lady.
Okay, so I'm going to present the psychosocial part. So basically, when the woman stop menstruating, the first thing is not being able to pregnant, and then what is it, doctor?
Not able to conceive.
Yeah, not able to conceive. Correct. Okay. So this is mainly affecting the psychosocial health for the patient, especially if the person came from a more conventional background, especially in cultures where they focus that women, the main role of women is to produce child.
Alright.
And then in work wise also, it sometimes the menopause causes the woman to tend to feel more depressed and also face anxiety, which will reduce the work performance and also affecting the social relationship between family and friends.
Alright, good. Ada lagi? What else?
I think, okay, wait.
Hey, I get a hint here. This woman having dyspareunia. So what is the relationship with the husband?
So I think the emotional relationship between
it's,
the husband and wife will be affected.
yes, true. Yeah, affect the relationship with the partner. What else lagi? Just imagine, at the age, young age, having premature ovarian failure, to having early menopause. Aside having a concern of not able to conceive, and every time having a sexual intercourse with the husband, there's always experience pain, and probably that the husband it will actually say no, and then having the hot flush and as well as the night sweat will actually cause her lack of sleep, and that affected the performance at work. What else? It's kind of like this patient feel like she's actually like, oh, I'm getting so old already, isn't it? Because he's having all the post-menopause symptoms, isn't it? At a young age. So definitely the patient feel that he's actually aged faster. Correct?
Yes, correct.
Right.
It
So
also,
ada lagi?
basically it will cause decreased self-esteem and coping to difficult situation and changes in personality as well.
Okay, right. Okay, are you happy with what we have discussed just now? How do you find this case?
It seems simple but quite detailed.
Right. Let's have a short reflection here. Okay, Nani, what do you think of this PBL session?
I love it. At the first we use the whiteboard because usually when we use the words we tend to read it. But the thing because I noticed that I note down more when my friend use whiteboard to explain, but it's a bit time consuming, so the others cannot use it. So it's quite rushing at the end, but I do enjoy it.
All right, okay. Because my concern is that do you learn in this session, yeah? Because of the short limitation is that we didn't share a whiteboard, yeah. If not, everyone actually can chip in, yeah. Okay. Rania, anything that can improve this PBL?
I think I don't know. I think it's okay. It's just that just like Nani said, I think it's a little bit time consuming just when like everyone needs to share screen. It takes time on that particular reasoning. But other than that, I think it's okay.
You benefit from the session, huh?
Yeah, I do.
Okay.
There's I learned a lot more. Like there's a lot thing that I don't know actually. So I gained a lot of knowledge today.
Okay, all right. Damia?
Yes, miss, it's the same for me. And yeah, it keeps me on toes because you would ask questions that I don't think important, but it's actually really important.
All right, okay, thank you. Thank you for feedback. Shafika? Shafika, are you there?
Yes, doctor. Tapi just now Wi-Fi dia macam on and off.
Okay, tak apa. We try to accommodate each other, all right? No need to apologize, all right? So, anything from you?
About today's PBL, is it?
Yes.
Alright. For me, I think it's really helpful because since we didn't really cover about menopause in the lectures before, so this PBL really opened my eyes more about menopause, and I could relate it with daily life since my mom pun dah does not have a period anymore, so I can basically relate it lah medically.
Okay, all right. One more thing, my concern here, I takut kalau keluar exam. I'm not a pharmaco person, yeah. All right. I know that they are giving me a table on the names of the hormones in the HRT. I'm not sure whether you really need to know or not because I don't know. We check with your pharmaco lecturer, yeah. All right. So for me, we just keep it brief. Is that in HRT is actually is estrogen, treated estrogen alone, or also combined with either is estrogen combined with progestogen. It's a synthetic of progesterone. Yeah. All right. Ifa.
It's the same as others, but for the cons, macam yang my learning issue, I have misunderstanding about the learning issue, like relate it to the amenorrhea, and I didn't do that. So I just
The
explain.
galactoria relationship galactoria with amenorrhea and hirsutism with amenorrhea. Is that it?
Yes, because in first PBL, we didn't write the relation with the amenorrhea.
What do you write there?
It just says that to
Explain.
explain the absence of the hirsutism and the galactoria.
In this patient, right? Okay, okay.
Yeah.
Tak apa. It's okay. I'm not minding smart on this, but there's a thing is probably the learning issue. I think in this package, they does not do the changes on the learning issue part. Okay, never mind. But you all know, right, how to associate the relationship between the galactoria with amenorrhea and hirsutism with amenorrhea. Betul tak?
Yes.
Okay, all right. Thank you. Ani.
Me too, same with the others. I think it's easier to understand when we write it up on the board.
Right. Right on the board. May I ask your PBL ni is actually you present from your text or what? What is the
We
norm?
only have one face-to-face. That's why we use the document.
Document. All right. So when you explain, you did not explain as what you did today.
Like this, doctor, for abnormal circumstances, we use the whiteboard and then we would gather, everyone would like speak up. But now we're using the computer, we just like present, show it here, the report that we gave to you or to other lecturers. And then from there, we'll take turns to explain our points. So it is up to our creativity whether or we want to read it or we want to like explain it in our own words. So most of the time we would first read whatever we've written and then explain if there's some difficult things to understand. So that's how it is usually is.
Okay, so now you actually get a shot of I making you to explain in a concept map and in a whiteboard, huh? Is it? Is it very different for you today?
It's not very different. The first time the conventional way that we do it is like this.
Okay, all right, okay. Tak apa. All right, Jolly.
Sorry, Miss, I'm outside for a bit, but I'll tell my part. Overall, I think the PBL session was great, and I think I enjoyed it this way because now I realize this parts that I missed out during my part of the PBL session. So I'm gonna update that later. And thank you, Miss, for mentioning about how estrogen affects, other than like more in detail about the uterine about the uterine wall. So because like in the textbooks, it wasn't that it wasn't really explained in detail. So I'm gonna look it up later.
All right. So mind you that I didn't go everything, but it actually have estrogen have many effect on the fallopian tube, on the cervix, on the I think many parts. Right? So you have to look out for it because I cannot go through into details. It's because of the time constraint. Thank you for Jolly. Mashita.
Oh yes. For me, I think this PBL session is great, and I learned a lot because like before this, since we only use the document, it's more like reading, and even like they explaining, we still explain like the same thing that we have put in the document. So when we do like this, it's more like discussions and more simple when they explain it, so it's easier to understand.
All right. Thank you, Mashita. Sarah.
For me, doctor, it's the same. Like when the question was asked, what is POI. I just defined like exactly the definition given, but I guess next time we also have to include on what basis do you diagnose, or how do you diagnose the disease in the
Yes, yes.
definition.
Yeah,
And
because yes.
no, that's it.
Okay, so remember POI is categorized with amenorrhea, but also it had to be supported by the evidence base. It's actually low LH, yeah, and FSH, and high what you call it, gonadotrophic releasing hormone, and high FSH and LH, yeah. Not gonadotropin releasing hormone, sorry, gonadotrophic hormones, yeah. So that would be the correct definition, and that is supported evidence based, yeah. All right, Pagis.
So I think what's different from what we've learned from you, I think it's very good that you try to ask us to explain in a way that we understand and help others to understand in a simple means instead of like reading the long text, but try to summarize it in a way they understand. And then on the first part, you ask us to like correct the case summary. I think it's very beneficial for all of us. Thank you.
Okay, all right. Farah,
Uh,
are you with me?
yes, 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 I am.
Okay.
So for my part, I would like to tell that first, thank you for the updates of some information from my part, the sign and symptoms. I think for this PBL, it kind of made me realize that I need to gather more information in my part, and I also can understand others' parts as well, because the way we conduct this PBL is such different from other PBL sessions that we have. So I think this one is kind of um, have much more interacting with each other. So that kind of make me more understandable, much more understanding in every topics that have been issued in the learning issue. So thank you. That's all.
All right, thank you, Farah. All right. Okay, first of all, is that I've been I'm no longer with FOM. Yeah. Now I'm at faculty head of science, and the lecturers say that they are actually not enough staff, so I'm trying to help out. Forgive me if I'm lacking in some area. I used to handle PBL face to face, and this is my first time online. That's why I'm actually getting feedback from each of you. We know that the epidemic, we actually try to adapt. So I hope all the best in your final exam. Actually, there's a lot of effect on of the estrogen and progesterone, yeah, especially like respiratory rate and also the electrolyte balance, yeah, that we did not discuss. Please look into it. And also about the thermogenic effect, yeah, of the hormones as well. Which hormone you have to find out. I actually tried my best to actually discuss, and actually more importance is actually more on the pathophysiology as well. I could not. I couldn't have time to actually correct on the concept map, but thank you for giving me the concept map. Yeah, so I hope that the feedback on the case summary, I think some of you done a very good job on the case summary. Yeah, please, if it's information that is not remarkable, it's not important for the case, you can actually no need to mention. Like for example, if the what you call it, the IBC profile is normal, you don't need to include in your case summary. Yeah. So with that, thank you so much, and I take this time what you call it, the attendance as a full attendance. Yeah. All right. So that's it. Thank you so much.
Thank you.
Okay, thank
So
you,
much.
Miss.
Thank you, Miss.
All right. Thank you, Miss.
Okay. Thank you.
Thank you,
Welcome.
Miss.
Thank you.